Good morning. Yeah.
Morning. Sorry,
Yes.
it took a little while.
No. It's a good morning. Today we will have a MRI session. Dr. Shubhra Rai Chaudhary, who is a very renowned interventional radiologist in Kolkata and very passionate teacher. So he'll take us through different MRI. Although this MRI plate is not showing the DNB or MS exam, because even surgical faculty has difficulty in interpreting this MR fistulogram. So Dr. Rai Chaudhary will give us a anatomical delineation of this area and how to interpret a MR fistulogram. Dr. Rai Chaudhary is attached to Fortis Hospital now and is a renowned interventional radiologist here. Dr. Rai
Anatomical Hospital.
How I chat, sir.
Oh, sorry. So anyway, thank you very much for the invitation, Dr. Shah. Always a great pleasure. As an ex-surgeon, it is always very nice to speak to young surgeons. I am going to hopefully my screen is being shared.
Yes.
You can hear.
I can hear you. I can see.
Okay. This in terms of MRI, in terms of assessment, and the principles of fistula and MR guided surgical intervention. So it's very similar to the talk that was given last year. Makunda, there's not much change in the content.
Yes. No, it's okay. They are new batch of students, so same may be very good for them.
Okay. So let me just go with a little bit of a background and a bit of a history in terms of we'll do this over half an hour, 40 minutes. So I'll start with this. Fistula in is a very common condition with an incidence of about 8.6 per 100,000 population. The main aim of imaging is to identify high and complex fistula to reduce the incidence of recurrence or to reduce the risk of incontinence following sphincter injury if you are going to divide the sphincter to reach the fistula. So you need to identify which fistulas are the ones that are complex. Now, that is what our traditional thought was, that we need to identify the high fistulas and the complex fistulas, particularly with the side extensions and the tract abscesses, so that will reduce the recurrence, right? But I must admit that what has happened practically over the last 10 years is that virtually every patient with a perianal fistula gets an MRI. In the old days, it was not the case. In the old days, the low simple fistulas would be operated directly by a surgical examination at EUA or by clinical examination. But to be honest, times have evolved with the ease of MRI and the fact that a lot more people can interpret this sort of MRI nowadays. I think you guys will agree that virtually every patient with an MRI, a fistula, gets an MRI, right?
Yeah.
Yes. Now this is a change in thought process. So, so what is the main role of MRI? The main role of MRI is to use to identify the primary tract and what are the complex features of the fistula in ano, and I'll talk about those things. So it is an interesting disease. It is one of the oldest surgical disease. Do you know that right from the times of Shakespeare to King Lear to one of the oldest surgical textbook is actually on fistula in ano, and as you can see that this is not that untrue even today. This is a quote from a textbook that I know not in all my time or heard not in all my time of any man, neither in England or in parties beyond the sea, that can cure a fistula in ano. So it is something that is fraught with recurrence. That is something that is a difficult disease to treat, and that has been known for a long time. Now, I know that all these recent modifications in terms of using laser, using video-assisted WAFT and all of these new methods of treatment. But one thing you have to bear in mind that whatever is the method of treatment, whatever is the way of either removing the fistula tract or closing the fistula tract, your primary job is to identify the fistula tract and identify the complexity of the fistula tract. So till recently, the surgeon's examining finger at EUA was the gold standard in classifying an anal fistula, right? Now the problem that is that
Some sound problem.
finger,
Yeah.
the main no difference that wound care. Ashana,
Hello.
can you hear me?
Yeah,
Yes,
yeah.
yes.
Yeah. So MR can identify, if you look at the causes of recurrence, the causes of recurrence are these, right? Inadequate drainage, MR can identify why. Poor wound care, it makes no difference. The lateral pockets, the superior extensions, submucosal tracts, MRI can identify. Identifying the correct crypt, MRI can identify. Presence or absence of Crohn's disease, MRI can identify. So if you look at the overall causes of recurrence, MR can identify all the causes apart from poor wound care. So the misconceptions that we had, and I don't think that this is a current misconception. I think surgeons understand this, that all tracts can be seen or felt at EUA. That is not correct. Endoanal ultrasound is superior. I do endoanal ultrasound myself, and I can tell you that it is not superior. MRI is expensive. It used to be the standard statement that used to be told to us that it is expensive. But an EUA is even more expensive, right? So to do that twice does not make any sense. So the aim should be to do the EUA and operate once, reduce recurrence by treating all the identified tracts. So that is what should be the aim. Now, if you look at this fantastic gold standard paper by Buchanan, is a surgeon from St. Mark's. If you look at this paper in 2004, where clinical examination was compared to anal endosonography and to MRI, and identification of the primary tracts or the abscess or the horseshoe, they were all superior with MRI. When you compare clinical digital examination, anal endosonography, or MR imaging. So this is a fantastic paper. If you get a chance, please do refer to read through this. Now the next question again by this particular paper is that if you look at, this is a Lancet paper around about the same time. If you look at 71 patients, so does it help the surgeon? In the old days, and again, as I said to you, this is when we were trying to convince the surgeons that everybody must get an MRI. I think the surgeons are convinced now. If you look at 71 patients with recurrent fistula in ano, and they were divided into two groups. One group was treated after an MR and then an EUA. So an MR guided EUA, and the other one was acted just on the clinical examination itself. And you look at the recurrence rates, 16% versus 57%. So MR was superior to surgical exploration for depicting all the tracts. So this is really, really important, that why do we want to do this MR? Now, when to image? So basically now the first line is applicable in all cases if you have the resource, because there is management change in 10%. So not often practical in a poor resource setting that everybody should get an MRI. In the setting of a poor resource setting, we should do it in recurrent disease. If we suspect a complex fistula, by how can we suspect clinically? As we know, the Goodsall's rule, further lateral the external opening is, more likely it is to be complex. And of course,
Some audio issues.
You guys are all lying, so in clock phase. Clock.
No.
Please wait, he has logged out. Might be joining again. Yes, Dr. Raju, you are back. मेल पटेल को देख रहा है
तो उसका लिंक देना
Oh, अच्छा हाँ, Dr. Rajudri, we cannot hear you. Screen is seen.
One second, boss.
Yeah.
Okay.
Yeah.
Yes, sorry. Can you hear me now, right?
Yes.
Okay. So these are the indications of currently imaging. So the clock face. Okay. So now let us talk about the anatomy. Okay. So I will show you with MRI pictures, but let us first understand the surgical anatomy very clearly. So, and this is something every radiologist has to understand. Okay. So if you look at the coronal plane and the axial plane, these are the two planes we are going to use. So in the coronal plane, which is easier for you guys to understand, what you need to understand is that here is the external sphincter, right? Which continues superiorly as the levator plate. Then we have the intersphincteric plane, and then the black is the circular muscle being continued as the internal sphincter. So these are the two really important sphincters, and I will show you how to identify them on MRI. So you have got an internal sphincter which is black, external sphincter which is gray, and the intersphincteric plane in between, right? Then you have the dentate line that is roughly 1/3 the way up the anal canal, roughly 1/3 the way up the anal canal. You have this dentate line. You cannot see the dentate line on MRI, but you can infer the position from the height of the anal canal, that where is the dentate line. Now, the importance of the dentate line is because the anal glands open in the dentate line, and that is usually almost always the source of the start of the anal crypt inflammation, which leads to the abscess, right? So the principle of a fistula is what? You get an anal gland inflammation at the crypt. Here is the crypt. You get an anal gland inflammation. That becomes a pus or an abscess. Now that tries to find out the easiest way out towards the skin, right? To decompress itself. And thereby you get a fistula. So you start with a abscess, then you might have a submucous or a localized tract, and then it will later on go extend to become a fistula. Okay, so that is the pathophysiology. So this is the coronal plane. Then on the axial plane, you're going to have the mucosa. Then you're going to have the internal sphincter, which is the black line here. And then you're going to have the external sphincter, which is the sort of gray block here. And this is the front of the external sphincter. And the external sphincter will continue anteriorly at the right level as the puboanal sling. So the external sphincter, like this, will carry on as a puboanal sling, and laterally will go up as the levator plate, right? And inside that is the circular muscle of the rectum that will come down and will thicken to form the internal sphincter. And in between the internal sphincter and the external sphincter, you will have the intersphincteric plane, right? That is the surgical anatomy. And then this triangle is called the ischianal fossa, as you know. So those are the things that, and then you have the external anal cleft or the, natal cleft, if you can call that. So these are the important landmarks you need to understand. So again, to give you the same picture, so here is the triangle of the ischianal fossa. Here is your levator plate. Here is your continuation of the external sphincter, dentate line, internal sphincter, and then this is the level of the natal cleft, right? And the surgical pathology that I described, that where these abscesses can be. So next, let us go to this, because I know that you guys know this very well, but it still is important to go through the surgical anatomy, because at the end of the day, with MRI, we are only trying to reproduce the same surgical anatomy. Okay. So this is the parts classification of the 4, or according to some people, 5 types of perianal fistula. So the first one is the intersphincteric fistula. The external opening is close to the natal cleft. Then it will go between the internal and external sphincter and open into the dentate line. The least complex fistula, these are usually treated by just laying it open. There is no need to do a need to bypass do a colostomy or to decompress the colon. These are the simple fistulas, right? The next one, which is also classed as a simple fistula, is a transsphincteric fistula. The transsphincteric fistula is usually 2 types: the low transsphincteric fistula or the high transsphincteric fistula. By definition, as you can understand, transsphincteric means that it crosses the external sphincter. The intersphincteric fistula does not cross the external sphincter. It goes between the external and the internal sphincter, whereas the transsphincteric fistula will cross the external sphincter. If it crosses quite low like this, it is a low transsphincteric. If it crosses high, then it is high transsphincteric. High transsphincteric can be a complex fistula. The other 2 are the rarer fistulas. So these 2 fistulas combined make up about 80% of all the perianal fistula. These 2 make only 20%, of which extrasphincteric is the most complex, the one that starts very laterally and then goes outside the external sphincter and opens not at the dentate line, but in the rectum, higher up in the rectum. So usually associated with Crohn's disease. This is very rare. This is seen in 5% of cases. And the one that is seen in about 10% of cases is suprasphincteric, whereby the fistula tract will go outside the external sphincter, will go up to the levator plate, but not above the levator plate. So it will stay below the levator plate, whereas this one is above the levator plate. Do you understand? This will stay at or below the levator plate, then come down in the intersphincteric plane and open at the dentate line. So all the 3 fistulas which stay below the levator plate will open at the dentate line: intersphincteric, transsphincteric, or suprasphincteric. Extrasphincteric fistula that will go above the levator plate will open above the dentate line. Now, this is the broad definition. Now, of course, there are complications. You can have a suprasphincteric fistula, which is the primary tract is below the levator plate, but a side extension that goes above the levator plate. So you have to understand that what is the primary tract and what is the side extension. And I'll explain that to you in a second. So the other thing that you guys know about is an anterior and posterior fistula. You know that the anterior posterior fistulas open at the midline usually, and anterior fistulas open anterolaterally, and
Good
they
sir.
extend.
Good sir.
Good salts, and they extend along the anterior anosphincteric raphe, which is the anoscrotal raphe. So it is very important to identify. I have all through my life I've seen fistulas opening on the inner thigh, opening as people thinking them as an inguinal abscess, but basically it is from the back coming through the front and opening entrance. So whenever you find an abscess in the perianal region, including the inner thigh or the inguinal region, and you do not always examine the anal canal, because that is the most important thing that you need to do. Okay. So now, if we have talked about the primary tract, now let us talk about the side tracts and what is the cause of recurrence. Because you as surgeons are very good to identify the primary tract. With an EUA, with a with hydrogen peroxide ultrasound, with methylene blue, all these sorts of things, you guys are very good at identifying the primary tract. What you guys are not good at on clinical examination is to identify the side extension, the tract abscess, and the horseshoes. And it is those extensions that cause the recurrence. Because the primary tract you guys deal with very well. Even when you're doing a laser, you know, the problem that all these guys are jumping up and down and doing laser everywhere, right? And the problem is that unless you are able to get your laser fiber into these extensions, you're going to get a recurrence. So it doesn't matter in what way you close the fistula, whether you open it, whether you core it out, whether you put a, you put a brush and then you put a laser, whatever you do, you need to treat every source of sepsis. If you have left a source of sepsis, it is going to recur. So what are those potential sources of sepsis? So if you have a primary tract like this, right, this is a transsphincteric tract. So look at this very carefully. So here is an intersphincteric tract. This intersphincteric tract can have, beyond this, a horseshoe that is going around the anal canal. Here is a transsphincteric tract. This can have an extension. See, the extension is outside the sphincter, right? But we are defining the tract by what is the nature of the primary tract. So you need to define it very carefully. So we'll show pictures in a second. So on this side, you can see that, look, this is the transsphincteric tract. Here is a side extension extending above the levator plate and causing a pelvic abscess. This is the pelvic abscess, right? This is inside the pelvic cavity. This is above the levator plate. On this side, you can have all of this sorts of anatomy, and hopefully I'll be able to show you some of them. So here is a intersphincteric tract, right? So this is a simple intersphincteric tract. So you've got a fistula. So we'll talk about the anatomy in a second. So before we do that, so the two common sequences we use to report and read is the stir sequence, axially and coronally. These two are the most important sequences. If you do GAD, if you give post GAD sequences, then the internal opening is seen better. And of course, if you can do a volume acquisition, then you can multiplanar adjust it in whichever plane you want. But broadly speaking, we use it by the stir sequences. But the stir sequence is not the greatest sequence. Makonda, you always want me to show the anatomy.
Yeah.
So I want to show you the anatomy. 1 second. Just give me 1 second, Mas. Okay. Okay. So I'll go back to my talk again, but I just wanted to show you the anatomy in these sort of sequences. So when you are looking at the MRI, then the circular, slightly gray muscle is the internal sphincter. So the internal sphincter is normally less than 4 millimeters in thickness. It is slightly grayer in color and it is on the inside. Now this is a T2 weighted sequence. Okay. So outside that, you will see the fat of the intersphincteric plane. On this is quite high up, but you can see the fat of the intersphincteric plane. And then on the outside, you're going to see the dark blackish circle of the external sphincter. So this is on the axial plane. And again on the coronal plane, remember that picture that I showed you at the beginning? So the external sphincter continuous as the levator plate, and the internal sphincter, which is a little bit more grayer in color. So external is darker in color, internal is grayer in color. So this is the circular muscle of the rectum, high up above the levator plate. If you come down, this will become the internal sphincter. Now, the reason I did not...
Dr. Rajudi, previous picture, what I was showing, what is this white area around the sphincter?
The white area here.
No, last picture you are showing. So outside the sphincter, we are seeing a this area. This yes.
This is the ischianal fossa. This is the fat in the ischianal fossa.
Yeah.
So just remember that picture that we had on the coronal plane of the surgical anatomy, right?
Yeah.
So this white is fat because this is not fat suppressed. When we do a stir sequence, it is fat suppressed, right? That's why it becomes black. So that is what we normally use to report the fistula. But that is not great for the anatomy. That's why I wanted to show you the anatomy. For the anatomy, this is the ischianal fossa. This is the external sphincter going up as the levator plate. External sphincter going up as the levator plate.
Yeah.
The grayer inside muscle is the internal sphincter. And the white in between these two is the intersphincteric fat. Because fat is white. Okay. Now, when we do the fat suppress sequence, all this white will become black. Yeah.
Yes, yes.
So here, you've got a tract which is bright, white, bright, because it has got fluid. This is a fluid accentuated sequence, right? Stir, whereby you have suppressed all the fat. That's why the ischianal fossa is black, but the fluid is bright. Why do we want to suppress the fat? Because if the fat was also present here as white and the fluid was white, we would not have seen the fistula tract so well, right? That's why we want to suppress everything as black and keep the fistula tract as white. Now here it is difficult for you to understand, but this is the internal sphincter, right? This one here, and the external sphincter is further outwards. I must admit these are very old pictures, Makhonda. These are pictures from more than 15 years ago. The MR pictures nowadays are much better. I will show you some pictures later on. So this is the fistula tract. So as you can see, it is not even touching the external sphincter. So therefore, it is a intersphincteric tract. So it is like this. It is going, not even touching the external sphincter, crossing the internal sphincter and opening internally at the dentate line. So on the axial images, if you take an image through here, if you take an image through this level, what are you going to see? You're going to see this circular muscle, which is the internal sphincter. Then you're going to see the external sphincter and you're going to see a little dot, right? So it is going to be like this. This picture is very bad actually, but you can see a little dot. That's all you can see. This is the external, this is the intersphincteric plane. Now, an intersphincteric can have a horseshoe, right? So a horseshoe will appear as what? So you have an internal, see, look at this. So here is the tract going in, and then you have got this high signal around the internal sphincter within the intersphincteric plane. And on the coronal plane, you're going to see the horseshoe as two little dots, right? Because on the coronal plane, you're going to see the horseshoe as two little dots. So these are the two little dots. So this is the axial and this is the coronal, okay? So this is an intersphincteric with a horseshoe. Now, this is a transsphincteric, right? So it is going in. No, this is not a transsphincteric. This is still an intersphincteric.
Intersphincteric.
Sorry, apologies. This is still an intersphincteric. On the other hand, this picture is a transsphincteric. So this and this two pictures don't tally. This picture should have been coming from here and going like this. Follow this. So this is a tract that is starting on the left side of the natal cleft, ascending cranially and anteriorly, and going along the outside of the external sphincter in the medial part of the ischianal fossa, going up, then crossing the external sphincter and opening internally, right? So it actually, this is a wrong picture, boss. It starts here, goes like this, and then opens internally, right? So now as it does that, opens internally, there is also a little side extension that is going up. Now, when you guys do the EUA, you will feel this tract going in, opening internally, but you will not feel this little bit. So when you do a laser or VAFT or whatever you do, you go and treat this. If you leave this, that is going to cause the recurrence. Do you understand?
Yeah.
So this is the key aspect of MRI to identify. So this is a suprasphincteric tract, like I explained in this here. This is a suprasphincteric tract. You can see the tract going across, and then opening at the level of the dentate line. Extrasphincteric is like this, like we talked about. So here is a tract that is going up and opening internally inside the rectum. Here is a tract going up and opening inside the rectum. Okay. You can see the opening far high up inside the rectum associated with significant rectal inflammation. So that brings me to the basically description of the 4 basic fistula types. Now the MR techniques that are used, I've just explained to this. In the old days, we were explaining endoanal coil. We don't do that anymore. GAD, we have got a paper to show that GAD makes it better, but a lot of people don't use GAD, 3D volume flash, etc. We can instill saline or contrast and do an MR or CT fistulography. It is not required, let me tell you. So what is basically important is that there has to be a consistent way of reporting. What does your surgeon want to know? And do you report everything that your surgeon wants to know? And this is the standard pro forma of the report that should be there. Whether you say this in text or ideally, as I do with the surgeons that I know, I draw a picture. I draw a picture of what is on in a language that the surgeon understands. So you need to define your primary tract, right? Inter, trans, supra, extra, or is there just a sinus? It is not a fistula. Then you need to define whether there is a tract abscess. Within the tract, is there an abscess? You need to describe that. Is there any horseshoe, as I showed you? The horseshoe can be anterior, it can be posterior. The horseshoe can be at various vertical levels, right? It can be at the level of the dentate line, it can be above the dentate line or below the dentate line. And then you can have the side extensions. And the side extensions are the really important things. The side extensions can go up towards the levator plate, it can cross the levator plate, or it can also come down and open as a second opening. You know, when you talk about multiple openings on a fistula tract, let me see if I've got a picture. One second. Okay. So when you talk about multiple openings, how do you get a multiple opening? Because remember, the anal gland inflammation is only one. It is one anal gland that has got infected and has made a fistula. So therefore, you always have one primary tract. Now, let me go back to this surgical anatomy, right? Now, you've got an anal gland inflammation, right? And you've got a fistula. The fistula in this case, let's say, is transsphincteric. Now, what is happening pathophysiologically? What is happening? You've got a pressure of pus, and the pus is trying to come out, and it is trying to find out the path of least resistance, right? So in the process, it can come out like this. It can go make a side extension to go like this, but it can also do a horseshoe, right? So how does it do a horseshoe? From here, it goes in the intersphincteric plane, either across the front or the back. Now it reaches the other side, and then it can come down again as an extension. So that is why you get external openings on either side of the natal cleft, but with one anal gland inflammation. It is because the moment you see bilateral external openings, you are convinced that there has to be a horseshoe. Without a horseshoe, you are not going to get two external. You understand? If it is on both sides of the natal cleft, then you must have an interconnecting tract within the anal canal. Otherwise, how will the anal gland inflammation go to the other side?
How to make out which side anal gland is primary site?
So it can be difficult, Makunda, you are right. But the point is that what you need to identify is that what is your primary tract.
Yeah,
so your primary tract is the widest, the one with the most fibrosis. So on T1 weighted imaging, you're going to see a black line. It is the widest tract, and on EUA, it is the tract that you feel the most. Okay. So that tract should go from the external opening and open internally at 6 o'clock, 7 o'clock, 11 o'clock, wherever, right? So that is wherever is the internal opening and the external opening, and you connect the two, that is your primary tract. Everything else is a side extension.
Yes.
So I don't want to talk about this particular paper where basically just one little concept that you guys must have is what is called an outcome derived reference standard. Now, the concept is very simple. In the older days, I think you younger surgeons don't necessarily subscribe to this, but we had to fight with our surgical colleagues in the older days, where they used to think that their examining finger is the gold standard.
No.
And they would compare the MR against they would say is that under anesthesia, the gold standard is the EUA. So what we had to describe is that no, it is not the examining finger. So MR is not false positive. MR is true positive. Your examining finger is false negative. So therefore, the outcome derived reference standard is the combination of the EUA and the MRI. That is the reference standard to which we should compare. And I won't go through this, but basically, accuracy of identifying the primary tract, horseshoes, and locating abscess is very high, 80s to
So
90.
some more pictures.
Yeah, coming. So here is a very complex scan in terms of complex extension. So you can see that this is an abscess, right? This is a large abscess in the perianal region. This is a sagittal scan. I have not shown you sagittal images. The reason I'm showing you sagittal images is to show you the extent. See, this one is going in the pre-pubic, post-pubic space, retropubic space from the perianal fistula, opening nearly at the level of the umbilicus. So you can see these wide extensions. And here is the axial. So this is a good picture, Makunda.
Yes.
Here is the internal sphincter, the gray. Can you see? The black is the intersphincteric plane because it is fat suppressed. So the fat has been suppressed. Then the external sphincter is a slightly grayer thing here. So here you can see that it basically is, in spite of the fact that it is so complex on the sagittal, look how complex it is. But it is actually a transsphincteric tract only. Because here is the fistula, primary tract. Here is bending it. This is the tract bending like this to open internally at the level of the dentate line at 5 o'clock. Can you see that? So the tract has come. This is axial. So I am not showing you all the pictures. So the tract has come like this. It has come like this. It has opened internally at the level of the dentate line. But the problem is the side extension. This is going outside the external sphincter in the retropubic space and then going up and up and up and opening at the level of the umbilicus. Okay. So looking at this, you would say that this has to be a complex fistula. But actually, no, this is still a low consphincteric fistula, but with a complication. Okay. Okay. So here, Acha, let me start with the axial. Okay, guys. So can you see this, follow this now? So here is a movie. So we are coming from the top. So can you see the muscles now on
Yes,
this
yes.
particular slice? This is the internal sphincter,
Internal sphincter.
gray. The black is the external sphincter. And here, little white, this is not fat suppressed. You see the intersphincteric plane. Yeah, this is the primary tract. Okay. So if you follow the primary tract from the below, this is the natal cleft. So it starts just to the left of the midline, goes anteriorly and cranially, staying outside the body of the left external sphincter. Okay. And we do not actually see it opening internally yet. Now it is going across the ischial fossa and possibly turning downwards. Okay, just 1 second. Oops, sorry. Okay, so from here, what we have to work out is it turning downwards to open in the dentate line to be a suprasphincteric fistula, or is it going up above the levator plate to open into the rectum to become an extrasphincteric fistula? That is what we have got to identify. Okay, so I've forgotten this case actually. So as you can see, it's not so easy. I do think that it is crossing the levator plate, right here, and it is an extrasphincteric. But to be honest, we do need to look at all the other sequences. Okay, so here, oh, sorry. So there is absolutely no internal opening that I can identify. So I think it is going up. I'll show you in a second. I think it is going up and opening just at the junction of the rectum and the anal canal. So this is an extrasphincteric fistula. But I guess you've had an idea about the internal external sphincter and the relationships of the various tracts. Okay.
Rajudri, previous picture. Can you show us the lateral structures? What are the normal lateral structure you are identifying? Just anatomy in the MR.
Okay.
Yeah. Just beyond the rectum. What are the adjacent structure you can identify?
Okay. So, okay. So this is a mid-perineal scan axially. So this is the symphysis. This is the pubic symphysis. Okay.
Yes.
This is the symphysiopubic joint. Okay. Here you can see a little bit of the ischium. This is the femoral neck. Now, if you look at the perineal structures, then this is the retropubic area, right? This is the pubis. So this is the retropubic area. This is the retropubic fat. Then you have the urethra here. This is the urethra. The black line is the urethral sphincter, the external urethral sphincter. This is that black line, right?
Yeah.
Beyond that is the vagina. See the vagina? Okay. Beyond that is the rectum or the anal canal. So this is the midline three structures. So if you want to see that coronally, so again, front to back, of course, coronal, front to back. So this is bladder. This is the pubis. Now, as you come down, here is the urethra. Okay. Coming down, then you see the little bit of the vagina, and then you see the rectum. So this is on the
anterior to posterior.
Coronal, front to back. So what you need to identify is the axial. So the axial is the best sequence for you to identify. So if I go up a little bit, let me start at the top. Here is the bladder. Okay. This is the uterus. Hip joint, acetabulum. Sacrum is at the back. Okay. So this is piriformis at the back. Right?
Yes.
Sacral hollow, piriformis, presacral fascia, fascia Waldeyer. Right? Then you have the obturator internus on the side of the pelvic side wall. Yeah. Then if we come slightly further down, again bladder. This is pectineus. This is okay, 1 second. So here is your levator plate. Can you see the levator plate? External sphincter going up as the levator ani.
Yes.
Okay. These are the the adductors are these. So this is pectineus, right? Should be pectineus. Yeah. So as you come down, so going up, pelvis, 3 organs, bladder, uterus, rectum. As you come down, still bladder, cervix, anorectal junction, and then below this, the perineal structures, urethra, vagina, and the anal canal. And then you have the puboanal sling. This is the puboanal sling, right? These are the pelvic side wall muscles. And this is the ischianal fossa that you were talking about.
Yeah.
Okay. Okay, Makunda?
Yes, 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 yes. So usually, as I said, these pictures are not given in the exam, but they are difficult to interpret by the surgeons.
I think to be honest with you, I must put some newer pictures because these are still very old pictures. It's just because that the newer scanners are a lot better, so you identify the anatomy a lot better. But are there any questions from the boys?
Yeah,
And the girls?
anything in the chat box, you can put your question if you have any query.
Okay.
So if you have a opening higher up in the rectum, it's most likely that it is not because of a primary anal gland infection. It might be a Crohn's or some other pelvic abscess secondarily pointing out.
Yes.
So identifying that, can you make out in MRI that this is a blind track going up? Because in that case, treatment become easier.
Yes. So that is what we call a sinus. So
Yeah.
it will, the sinus, I should have shown you a picture. This, just give me a second.
When you are saying that there is no opening in the upper tract going sideways.
No, it is the other way around. You're always going to have an internal opening because that is where it starts.
But that may be in the anal gland crypt. What I'm saying is if side track going on the parallel to the rectum, then usually that does not have opening higher up. If it is a primarily anal crypt infection.
If it's a primary anal crypt infection, but it has not opened externally into the perianal skin.
It is open, but I'm saying it's side tract. Side tract is usually blind.
Oh, the side tract is almost always blind.
Yes.
Side tract is almost always
so
blind.
You can comment in MRI that yes, I'm
confidently. See, once you find one internal opening, you should not try to go hunting for another internal opening. So
someone put a question. Put a question. Transsphincteric, you said, what is the landmark? At what point is a high transsphincteric or low transsphincteric? I think it's the levator.
No. Above the levator, it becomes supralevator, right? So just one little thing. I am sharing this one little picture. So whenever you have a fistula tract like this, can you see the picture?
Yes, it appears horseshoe on the axial.
So whenever you have this is a fistula tract only, but lower down it is slightly irregular. You can see this hyperintensity. So you have to think about 5% of fistulas or anorectal cancers will present as a fistula. So if you have a nodularity or irregularity, then always suspect a cancer. But all of you, when you do an EUA or even an PR examination, you will identify the cancer anyway. But just on imaging, it is important to identify that, right? The submucous tract, I was going to talk to you. See, the Makonda, the problem is that these videos I would have shown you, but these videos, because of the change of computer, these videos are not working. I have this case 1, 2, 3, 4, 5, 6, but last night when I checked, I could not see the videos working. Okay, one second. Submucous, right? So now this is for pelvic floor. I'll drop that. Okay. So the chat question is what? How to identify between a high and transsphincteric to a
and low.
Good question. So if you mentally divide the external sphincter that you can see into the lower 1/3 and upper 2/3, because roughly speaking, if the level of the the end. Let me go back to this picture. What was I showing you? So roughly speaking, if you are 1/3, this is the external sphincter, right?
Yeah.
So in the lower 1/3, if it crosses, it is a low, or if it is above the lower one, above the line of the lower 1/3, then it is high. Okay. Makunda, I've got to go.
Yeah,
Is
yeah,
that
yeah.
okay? All right.
Yes, 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 fine. So we
Okay.
have one more class, I feel, on Tuesday.
Yes, yes.
MRCP, is it?
Yeah,
Okay,
yeah.
okay. Okay.
Thank
All
you.
right.
Thank you very much.
Okay. Thank you. Thank you.
Nice.
Bye.
Bye. Thank you.